Board Bombs.
Welcome back to EM Board Bombs. I'm your host, Blake Briggs, co-founder, co-host. Hey, we got an exciting opportunity here on Board Bombs podcast here. Real quick, if you're a med student on your EM rotation, this one's for you. We have an awesome new product for you. And if you have that EM shelf coming up that's breathing down your neck, or MBME, or you're worried about what the attending or resident is going to ask you on shift, then we have a game changer for you. We're officially launching this brand new podcast called EM Critical Hits, and it's already live. We've launched about a month ago, and we've done a little bit of a teaser with some med students giving away free episodes, and they love it. It's the ultimate audio resource for your EM clerkship and for the MBME shelf. It's 33 high-yield episodes, all under 10 minutes, designed to do one episode a day, all designed to take you from what the heck is going on in the recess bay to confident, competent, and completely, attending proof, meaning that you won't get stumped on questions. So each episode, we give you one shelf-style clinical question and then a step-by-step breakdown of those answers, crucial teaching points for the exam and real life. We tell you what you're going to be asked about in real life versus the test answer. And yes, of course, the standard EM Board Bombs jokes and flavor. So it's perfect for your commute or your lunch break or when you're walking to the ED. If you have a walking commute, that's pretty awesome. So we made this because most possible to finish in between shifts because you don't have the time or the inertia to start that. And we're solving that with EM Critical Hits, 10-minute episodes, speed, relevant, maximum retention, drip learning model, no fluff, no filler. It's really what you need and fast. So if you already love EM Rapid Bombs, you love EM Board Bombs, love our handouts, you know how we roll. You're going to love EM Critical Hits. So check it out and go to our website here in the description. You'll get a very, very generous discount on our new product here, and you're going to love every second of it. And here's a preview we're going to give you here in a second for you to really get a sense of what you're in for when it comes to EM Critical Hits. See ya.
EM Board Bombs.
Welcome back to EM Board Bombs. I'm your host, Blake Briggs. Happy to be here. Hey, so awesome stuff this week. We're giving you a sneak peek of our latest product from EM Board Bombs. Pretty exciting stuff. EM Board Bombs, again, the show that gives you pretty much everything you need to know as an emergency medicine clinician for boards and life. You can tell this is my day off today. I'm not clean shaven at all. I'm looking myself in the camera right here and shrieking inside how day offish I look. Anyway, hey, so on my day off, even, I'm giving you our latest product here from EM Board Bombs. And hey, this is a shout out to all the med students out there. If you're a medical student on your EM rotation, this one is for you. So maybe you got an EM shelf on the way that you're not excited about. Maybe it's just breathing down your neck and you're like, okay, I'm going to have something game changing here to study. We're officially launching a brand new podcast. It's already out there. EM Critical Hits. We just launched it last month. It's the ultimate audio resource for your EM clerkship and the MBME shelf exam. We're giving you 33 high-yield episodes, and they're all under about 10 minutes. All are designed to take you from a what the heck is going on in the trauma bay or recess bay to confident, competent, and ready to completely answer every question correct the attending may ask you. So each episode gives you one shelf-style clinical scenario. We talk about a breakdown of the answer and the incorrect answer choices, the crucial teaching points of what the MBME shelf is going to ask you, as well as what your attending is going to ask you, or resident, whoever is going to teach you. And yes, just enough flavor to keep things exciting, just enough of the jokes, the classic EM Board Bombs regimen of humor. It's perfect for your commute, lunch break, whatever, if you're walking to the ED. If you have a walking commute, that's pretty awesome. Wondering if you'll be asked to interpret that weird EKG again. Now you'll know when you look at our stuff and listen to our awesome podcast. You know, the reason we made this was, let's face it, most EM shelf prep out there is either a massive textbook, which is completely outdated, a 500 question Q bank that takes hours to get through and you hate every second of it, and none of those answers are like real life appropriate. And if you say it in real life, they'll laugh at you. Or just a quick podcast which is ours. 10-minute episodes telling you what you need to know. It's built for speed, it's built for relevance, it's built for maximum retention. There's no fluff, there's no filler, and it's what you need. It's not any hype that a lot of things are marketing nowadays. It's built by academic attendings. Myself, Dr. Hussein, and Marlena Wasiski-Kuhn, of course. Dr. Marlena Wasiski-Kuhn, sorry. Remember, she has a PhD. So we're not trying to be a traditional Q-Bank because I think we're better than that. This is a focused, curated audio content that teaches while mimicking the feel of what you're going to get on shelf or step 2 questions. And you're not just memorizing. We're telling you how to think EM, how to think like an EM clinician. And unlike other platforms, you're not paying hundreds of dollars for access. This is an insanely affordable subscription. It's essentially like a giveaway. So go to the link here in our podcast description here. Listen to this episode I'm about to give you a sneak peek of, and you'll be enthralled by it. Hopefully you'll listen. And if you're not a med student listening to this, then please do us a solid and refer some medical students to us. And we're happy to help out. We got this awesome podcast here at such a cheap rate, and we really just want to enhance EM education for medical students out there. So here's a sneak peek. This is an actual excerpt from our EM Critical Hits episodes. Let's go. Roll it. All right, next episode here, you have a 31-year-old female presenting to the ED with palpitations and dyspnea. She states she was in her usual health and making breakfast in the kitchen this morning when it started. She denies this occurring before. Her EKG has regular, narrow tachycardia, no P waves are seen. Vital signs are notable for a blood pressure of 130/90, a pulse of 158 beats per minute. Bedside maneuvers are attempted and failed. Adenosine 6 milligrams is attempted and fails. What is the best next step? Choice A, adenosine. Choice B, electrical cardioversion. Choice C, metoprolol IV push. Choice D, diltiazem IV push. Okay, so this next episode, we're going to chat about another giant in the ED, tachyarrhythmias, or tachydysrhythmias, a long word. Either term is fine. Both are actually quite annoying to spell, though. So SVT, supraventricular tachycardia, is the most common cause of palpitations in patients with structurally normal hearts. There's a very good chance you'll see SVT during your rotation on EM, so you need to know the steps in its management, like backwards and forwards. You'll be tested on it. But wait. Before we go into more about SVT and its treatment, we obviously have to cover tachyarrhythmias in general. Students that work with me on shift always seem to hesitate when approaching these, and I think it's because no other medical field or any other part of medical school actually teaches how to manage these. Maybe cardiology, but they deal with them more downstream. So leave it to EM here to straighten things out. So the best way to approach tachyarrhythmias in the acute setting, like fresh into the ED, tachyarrhythmias, is to simplify them into 4 categories based on whether the rhythm is narrow or wide and regular and irregular. There is this great one-page study guide on our website that summarizes this, and the link will be at the top and bottom of this podcast description. You can click on it and check it out and take it to work with you. It's really easy to memorize. When someone says narrow rhythm, that means the QRS width should be less than 3 little boxes on the EKG paper. Or if you like precision, that's less than 120 milliseconds if you have a pair of calipers. When we say regular or irregular, that means the R to R interval between the QRS complexes should be consistent on the EKG paper. We suggest using calipers for this to be absolutely precise, plus people know you're a serious nerd when you pull out calipers while on shift. #respect. Thankfully, each category that we're talking about here only has about 3 to 4 rhythms in each one, so let's break it down by each category. Narrow, regular tachyarrhythmias, that includes aflutter, orthodromic, Wolff-Parkinson-White, and paroxysmal SVT, the topic of this podcast. The second category are narrow, irregular tachyarrhythmias, and that would include AFib, of course, by far the most common, aflutter with a block causing it to be irregular, mixed AFib or aflutter, or this rare one that's high yield for boards called multifocal atrial tachycardia. Then we get into the wide rhythms. There's 2 categories here. Wide regular tachyarrhythmia, which includes ventricular tachycardia, SVT with aberrancy or antidromic Wolff-Parkinson-White, and then finally wide irregular tachyarrhythmia, which is a very strange, weird-looking rhythm, very foreboding, atrial fibrillation with aberrancy, polymorphic VT, or Wolff-Parkinson-White with AFib. Now, there are a few exceptions to these categories, but this is like 90% of what you're going to see in the ED, especially during your month with us. So don't bother going in more depth than what we've done so far. The best part is the management for each is quite similar. First of all, any patient that is unstable, no matter the tachyarrhythmia, will get shocked. Let's say that again. Any unstable patient with a fast heart rate, that's not sinus tach, will get electrical cardioversion. The test will never ask you the dose of electricity, but your supervising attending or resident might. So the answer is, quote, go big or go home. You can say that if you want to. But ACLS and BLS try to use different doses depending on the rhythm, but we believe, and we're not alone on this, to go big or go home on every single shock. That means 150 to 200 joules, really 200 joules, is the right call when you're using external pads for cardioversion, synchronized cardioversion. As for unstable patients, what does that mean? This brings up our next ABC talk. Remember last episode we talked about how on this specially tailored medical student podcast, we're going to be going through the ABCs, because as a new member of the EM community, you will be tested and asked about what ABCs mean on your rotation. So let's cover the A and B part together in this patient. Patients with tachyarrhythmias usually are alert and oriented for a while until they can no longer compensate for their poor perfusion from a rhythm. You might see shallow breathing, diaphoresis, and minimal speech as they deteriorate. This can happen slowly or quickly depending on the patient's age and comorbidities as well as the rhythm type. Obviously, patients with AFib look a lot better in general than patients with VTach. When it comes to patients with tachyarrhythmias, the letter C for circulation needs to be emphasized. Feel for peripheral pulses. That's part of the unstable part of evaluation. Check for a CAT refill. Look for JVD. Monitor for drops in blood pressure or signs of shock. Here's a pearl for you to remember. Any unstable with a tachyarrhythmia, even if they need intubation, should always be shocked first. So if you have a patient coming in and they are not breathing and you're saying, wow, the ABC's A is not intact, their airway is not safe, and they are not breathing, but you notice VTach on the monitor, you are shocking them first. You are not intubating them. That is such an important point. So how do we manage these tachyarrhythmia patients besides shocking the unstable ones? Well, ABCs, you're going to be dual IV access here, large bore, have airway equipment nearby. One thing I see a lot of people forget to do is preemptively place pads on the patient and turn on the defibrillator. Just turn it on. Doesn't mean you shock them, just turn it on so it can start sensing the rhythm. Even if the patient is stable, you never know when they won't be, and then you need to have your finger on the trigger, as they say. Okay, now that we have the basics out of the way, let's focus on the SVT. SVT is a broad term used for any narrow, regular arrhythmia coming from above the ventricles, hence the name. This means it's either atrial or junctional. A lot of other arrhythmias can present really fast, like an SVT, and once you slow it down, you can then repeat EKG and see what the underlying rhythm is, like A flutter or Wolff-Parkinson-White, etc. The tachycardia typically ranges between 140 to 280 beats per minute, and it's regular in nature. It may self-resolve or continue indefinitely until medical treatment. So AV nodal reentrant tachycardia is typically paroxysmal and may occur spontaneously or upon provocation, like any type of exertion, caffeine, certain types of alcohol, beta agonists, or sympathomimetics like amphetamines, either prescription or illegal ones. To simplify the underlying pathophysiology, a premature atrial beat reaches the AV node, and if it arrives at just the right moment after a refractory period, the impulse can recycle retrograde up into the fast pathway, creating a circus-like movement. The impulse then will continually cycle around the two pathways and creates this crazy fast heart rate. Okay, so let's talk about the treatment. Well, again, if the patient is unstable, you're juicing them. You're giving them 200 joules of synchronized cardioversion. That's EM language for electrical cardioverting them, juicing them. What about stable patients? This is the vast majority of SVT patients. Sometimes they're even texting on their phone. Vagal maneuvers are talked about a lot, and they're just not that good. They're less than 50% effective, but you definitely should give it a shot, of course, and your attending is probably going to use that as a teaching moment to go over with you. The most common method I've seen is called the, quote, modified Valsalva maneuver, where someone is sitting upright in a bed, blowing against the end of a syringe and attempting to move the plunger on it. After 30 seconds of trying this, you quickly lay them down and lift their legs off the bed for 10 seconds. Give that a try once or twice if you fancy. This is a good thing to do and volunteer to do if the patient's able to be moved like that. And it'll make you look really good with your attending or resident to say that you've tried that already. If that fails, adenosine is up next. So adenosine is super short half-life medication. less than a few seconds. So you need to rapidly push it. 6 milligrams is the first dose, which is what our patient got in this question. However, that can often fail in a lot of patients. And if that does fail, ACLS in most societies state to give it a second time, but at a higher dose, so 12 milligrams. If this fails, you can reach into your box and grab metoprolol, typically, or less likely diltiazem. If at any point the patient becomes unstable, you are going to do what? Okay, I heard you. I heard you say it from far away. Yes, you're going to shock them. Once you convert these patients, always get a post-conversion EKG. Usually the defibrillator automatically prints out a tracing after any type of conversion of rhythm. Sometimes you have to press the record button. You're going to monitor these patients for a couple hours in the ED, usually about an hour or two. And the last word here is, what about labs after converting them? Lots of debate here. It's reasonable to get some electrolytes, a CBC, magnesium, urine pregnancy tests, common potential triggers of arrhythmia. Skip the troponin though. In any patient with no underlying heart disease, which is the vast majority of people with SVT, you shouldn't be getting troponins. Boards will not want you to do this. The tests will not want you to do this. Okay, let's do the learning points here and wrap this up. Really about tachyarrhythmia management. They're divided into 4 easy to remember categories. I'm not going to read these off again. They're going to be in the description of the podcast episode below. Just remember that SVT, or supraventricular tachycardia, is the most common cause of palpitations in patients with structurally normal hearts. In stable patients with tachyarrhythmias, like SVT, you're going to try the Valsalva maneuver, followed by adenosine, followed by double dose adenosine, so it's 6 milligrams, then 12 milligrams, and then debate moving to metoprolol or diltiazem or electricity. Anytime a patient is unstable with a tachyarrhythmia, you're shocking them immediately. You're going to do max dose, 200 joules every single time, and you're going to make sure that the pads are on appropriately, anterior posterior or anterior lateral, and you're going to do synchronized cardioversion as long as they have a pulse. Always, always, always address a patient's tachyarrhythmia before intubating them. So important. And that's it for this episode. Thanks for tuning in. All right, that's a wrap on this episode of EM Critical Hits, one of 33 rapid-fire, high-yield episodes we built specifically for medical students crushing that EM rotation and crushing their EMBME shelf exam or SAM shelf exam, whatever. If you found this helpful, there's so much more waiting for you here. The full series is available exclusively at emboardbombs.com. Just go there under the medical student tab at the top and you'll find this series here. You can sign up in just 2 clicks. Every episode is about 10 minutes long. Every episode teaches you how to think emergency medicine, not just memorize it. So go subscribe today. Let's help you dominate the shelf, stand out on shift, and never freeze up when you're asked questions as well. Again, emboardbombs.com. Links in the show notes. We'll see you there.